Students, welcome. I think we have our last person that just joined us. If you're able, it'd be great if you could turn on your cameras because this session is like a mock lecture. And so for like the Farm 100 and Farm 200 classes that are part of the 2 years of undergrad for APEX students, we have pharmacists come in from a bunch of different areas of pharmacy practice, which there's over 180 of them. But we want to give students exposure to different practice settings so they kind of hear about how that professor or that pharmacist got to where they are, kind of what they do in that role, and tips for students who might be interested in going into that role. So today we have with us Dr. Jerica Lamb, who has been with Chapman for several years, close to 10 now, or
Actually, 11.
11. Wow.
I
Yeah.
cannot believe it too.
I know. Um, yeah, you came in, yeah, a year after I came out here. So, but she's going to be talking about her role as an ambulatory care pharmacist. And I will leave the rest of the introduction because she's going to tell you all about herself during her presentation. But thank you guys for joining. And I'm going to turn it over to Dr. Lamb, who will have her presentation, and then we'll have some time for questions at the end. All right. Dr. Lamb, it's all yours.
Great. Thank you, Dr. Brown, for the kind introductions. Good evening, everyone. I know that it's probably after school for you. So while I'm doing this, let me go ahead and share my screen first. And that's what Dr. Brown was saying. I'll just briefly introduce myself. There we go. I think you can see my screen, right? Okay,
Mhm. You
great.
need to go to,
Mhm.
yep, like that.
Okay, great, great. Thank you. So, as what Dr. Brown has mentioned, I've joined Chapman in the early years. In 2014, Dr. Brown was on my search committee as one of my interviewers, and it's been a roller coaster ride. I can say that. I'm sure Dr. Brown can attest to that too, in terms of just growing any startup, building any startup company or program. It takes a lot of opinions and perspectives and also insight and experiences. As for myself, I got my PharmD, my Doctor of Pharmacy degree from USC School of Pharmacy, and I also pursued a first year residency in pharmacy practice after I graduated, and then returned to USC to complete my 2 years of research fellowship. My focus is in, or my practice is in infectious diseases, mainly in viral infections. So I do see patients in the clinic setting in ambulatory care setting, which I will talk about more in depth during this presentation. But many of our patients in the clinic, they do live with HIV and they do have co-infections with hepatitis, either hepatitis B or C. And many of them are living longer with the great treatments that we have for HIV. So they also have other coexisting conditions, health conditions such as diabetes, hypertension, hyperlipidemia. All of these disease states you learn more about if you do decide to pursue pharmacy or even healthcare in general. Okay, great. And this is going to be interactive. Feel free to interrupt or raise your hands if you do have questions along the way. I tend to, during Zoom, to minimize I guess the cameras where I see people simply because I do get distracted when I see people from my presentation. So I'm just going to minimize that. So if you have a burning question, feel free to put it in the chat or just raise your hands, and Dr. Brown can also help delegate the questions towards me as well. Okay? All right. All right. So at the end of this presentation, and also echoing what Dr. Brown has mentioned, I've given this presentation before, probably about 1 month ago, to the undergraduate students at Chapman, part of that APEX program that Dr. Brown leads. So this is the same presentation that I'm going to give to you tonight. So at the end of this presentation, you walk away with information to be able to describe what is ambulatory care pharmacy practice. identify the different types of ambulatory care pharmacy practice, and also the role of what an ambulatory care pharmacist is. And lastly, to discuss the impact of ambulatory care pharmacy services in the healthcare setting. All right. So to begin, students always wanted to know, what is ambulatory care pharmacy practice? How is it different from retail/community pharmacy practice? Well, I'm going to show you some information, share with you some information in terms of how they are different from the retail/community pharmacy practice setting. It is a provision of integrated, accessible healthcare services by pharmacists who are accountable for addressing medication needs, developing sustained partnerships with patients, and practicing in the context of family and the community. So technically, the analogy that I usually give to students is, many of you, I'm sure, have pediatricians that you've seen over the years as you were growing up, and you would go with your parents to get your vaccinations in the clinic setting. Well, many of the clinics now, not only in the state of California, but in many other states, there are clinical pharmacists in that clinic setting. So technically, we are your primary care provider. It's just that we don't have an MD or DO after our name. Rather, we have a PharmD after our name. And ambulatory care pharmacy practice is usually accomplished through offering direct patient care and medication management for patients who are on the outpatient side, ambulatory. So there's a difference between outpatient, meaning that we're all outpatient. We are not hospitalized. We're able to walk and do things on the outside of healthcare systems. In contrast, you have inpatient, and that's a common term that we use for patients who are in the hospital setting. So they're inpatient or in the hospital setting, and they're receiving care within the hospital setting. So for ambulatory care pharmacists, we take care of patients who are not as sick. They're ambulatory, they're able to take care of themselves, and they do come for regular visits for their to see the medical providers as well as to see the pharmacists. So ambulatory care pharmacists do coordinate care. They advocate for their patients as well as for their wellness and health promotion. And we do at times triage and refer patients to more specialists or I would say experts. Usually in my setting, we would refer patients who have really serious mental health illness to see their psychiatrist. And sometimes when we have a patient who has severe hepatitis based on their blood test results, then we would refer patients to see a hepatologist or a gastroenterologist, for example. We also offer patient education, and we try to empower patients to make sure that they understand the medications they're taking and how their medications are directly related to improving their health outcomes for their condition, whether it is diabetes, high blood pressure, or even high cholesterol. What I want to show you here is in terms of the finances. So one of the things that always come into play for any health system is to see if a service line or a position for a pharmacist is generating revenue or generating income. And this is just the overall outpatient versus inpatient gross revenue. So outside hospital and inside hospital. And what you can see here, as you can see back in 1991, this is before many of you were born, is that the revenue, the monies that health systems dedicate in terms of resources or hiring people or even offering various screening services, the revenue actually was not as much compared to the hospital revenue that was dedicated to. But over the years, as you can see, progressively up to 2011 or 2011, the gross outpatient revenue, the dedicated funds to outpatient or ambulatory care services have increased gradually. And you can see on the opposite end where the dedicated funding for inpatient or hospital services, hospital perhaps positions, nurses position, physician, pharmacist positions, all that contribute to that revenue. The gross inpatient revenue actually declines. And if I were to take you closer into the future now to 2016, this is the most updated information we have from this source. What you can see is that the gross outpatient revenue, and this was where we stopped at on the previous slide, 2011, it went from 43% up to additional 5% in 2016. Now, you've also seen that the opposite trend is visible here, where if we look into 2016, the dedicated funds to hospital revenue or hospital services also declined from 57% to 52%. So there's that seesaw effect where there's more money put into outpatient setting, ambulatory care clinics. And this has to do with screening, prevention, etc. That the main goal is to make sure our patients, such as yourselves, remain healthy so you don't need to end up into the hospital setting. So you can see where the trend is in terms of dedicated funds, but also you can imagine that there's going to be more positions opened for outpatient setting, where a lot of people, it's kind of like all hands on deck, where you need nurses, primary care physicians, ambulatory care pharmacists on the outpatient side to take care of their patients so that the patients remain healthy so that we can hopefully avoid or prevent hospitalizations from happening. So just to share with you, hospital outpatient care, the costs or the dedicated funds into these services increase, and then dedicated funds for inpatient hospital care is decreasing. Now, the other thing that I want to share with you here is that there is a shift from acute care setting, which is a hospital setting, towards ambulatory care, which is more community setting. And the reason is because we understand, based on a lot of research and literature, that the longer a patient stays within the hospital, the more cost ineffective they become to the health system, to the medical center. And so perhaps you may have seen your parents or your grandparents in terms of being hospitalized, that there is an urgency to make sure that they recover, they get well, and that they get discharged from the hospital. So the main goal for anyone within the hospital setting is to reduce their hospital length of stay, because the longer they stay, it's going to eat up the cost of that medical center. And the other thing that we recognize is that there's more dedicated funds to increasing outpatient procedures, and this has to do with diagnostics, preventative screening procedures, and also more positions opened on the outpatient side. And the main goal is to reduce healthcare costs for the whole system. For example, whether it is Providence Health, Kaiser, for example, or even Hoag. So everyone has that same mindset, is that we don't want the patient to stay in the hospital too long. We want them to stay outside the hospital. Ambulatory care pharmacists are essential in continuing that transitions of care, and I'll talk more about that later on in this presentation. But we act as a bridge between someone who is discharged from the hospital into primary care clinic. And there's also a role for pharmacists in that setting. It's called transitions of care pharmacists as well. But the main goal that ambulatory care pharmacists do is that we do medication reconciliation, and we do become essential key players in secondary prevention clinics by offering immunizations. We also manage their medications in terms of the chronic medications to minimize drug-drug interactions when a patient is discharged from the hospital to home setting. And the need for ambulatory care pharmacy actually is very evident. We see that the need is increasing significantly over the years. And in these various health settings here, and this is not a comprehensive list, but we see that there are ambulatory care pharmacy positions opened or at least created in hospital and health system clinics. I did my residency at the San Francisco VA Center, and one of the projects that my preceptor, my mentor, created actually translated into one full-time critical care pharmacist at the VA. Just to let you know, back then I was more hospital focused, so I wasn't doing ambulatory care. But just to let you know that many of the residency projects that occur in health systems, they are meant to create justification for a new position. And so a lot of projects now are emerging for the creation of ambulatory care pharmacists in whether it is a community hospital or whether it's a privately owned medical office building. Other positions that have been developed occurred in federally qualified health centers. I work at one of them, patient-centered medical homes, community pharmacies. And so maybe perhaps some of you, if you have a chance, next time when you go to a CVS pharmacy, there are certain CVS pharmacies that have admitted clinics. And so meaning that they do have a small clinic within that big CVS pharmacy or store. And so that's where patients would go and see their primary provider, whether it is a nurse practitioner or a PA. But we hope to have a pharmacist embedded in a minute clinic so that the pharmacist can be there to help the PA as well as the NP reconcile medications and also manage the patient's medications overall. Ambulatory care pharmacists are also found in physician offices or medical office buildings. I know classically Kaiser has a lot of MOBs, and they have a lot of ambulatory care pharmacists embedded in those MOBs. There's also an increased focus on smooth transitions of care between settings. And so one of the things that I share with many students is that among all the healthcare providers, pharmacists are the only drug experts. We have dedicated education and training to just understand comprehensively about the medications, their medicinal chemistry, their pharmacology, how they work, and also their clinical applications. And so we are poised to be right there in the front lines along with medical providers to really focus on the medications and make sure patients are getting or receiving the right medications and also not having any major drug interactions. There are many types of ambulatory care pharmacy practice settings, and let me just move this here because it's blocking there's many types of ambulatory care pharmacy practice settings. And what I'll share with you again is not the comprehensive list, but just a flavor of what is out there right now. There are many pharmacists in Coumadin clinics, and this actually was a traditional ambulatory care clinic service where there's a dedicated pharmacist to manage and monitor patients who are taking warfarin, which is the brand name of warfarin is Coumadin, which is an antiplatelet. It is a little bit stronger than aspirin, but it helps people to not develop clots where they can be at risk for having a heart attack or a stroke or even pulmonary embolism, for example. Pharmacists also are actively engaged in managing patients' diabetes, and that's in terms of their medications, also helping with educating patients about healthier nutrition and exercise so that patients can manage and improve their diabetes much better. ID pharmacists such as myself, we are also embedded in ID ambulatory care clinics where we manage the medications for patients who have HIV and hepatitis, as well as sexually transmitted infections. And there's a plethora more of positions open for ambulatory care pharmacists. Now, in order to do all these great things in the outpatient side, we need to have some kind of contract or agreement. And so many of the clinics operate in a format where there's a memorandum of understanding or a collaborative practice agreement. So for my clinic, for example, we have a CPA, collaborative practice agreement, that is signed between Chapman University and the senior administration of Ultimed, where I practice. And it is a formalized relationship where I work alongside the medical providers, including nurses, to manage patients and mainly focusing on their medications. Each state is different in defining the scope of practice, but usually when you're licensed and if you decide to practice in Las Vegas, Nevada, for example, or Phoenix, Arizona, you'll be able to take their law exam and know their various regulations and pharmacy law to know what is the scope of your practice in that particular practice setting and for that particular region of the state. There's also practice settings that are freestanding versus integration here. And for example, I gave you some previous examples where the community retail practice sites, such as CVS Minute Clinic, that is a freestanding community slash uh, clinic setting. And then we have ambulatory care pharmacy services that are integrated into Kaiser medical office buildings. And there are also ambulatory care pharmacists who act in the role of a transitions of care pharmacist in hospital-based settings where they see patients on the day of their discharge, hospital discharge, help the nurses reconcile the patient's medications before a patient goes home, and then of course give that warm handoff to their primary care provider to let the medical provider know that their patient is discharged and going home with these medications. And of course, pharmacists also play a big role in academic settings, such as Dr. Brown and myself. We are pharmacists by training, but we are also considered academicians. So we do teach pharmacy practice and we teach in the areas of our training and expertise. And these are, again, just some examples of the common types of ambulatory care pharmacy practice settings. We have pharmacists working mainly with patients with diabetes, pharmacists who are also embedded in the lipid clinics, in the hypertension clinics, pharmacists who are focused on the infectious disease aspect of the patients. And then there are other pharmacists who are specially trained to manage alongside psychiatrists, the patient's mental health conditions such as depression, schizophrenia, bipolar depression. Now, there is a wave moving towards comprehensive care. So in a way, and I'm a believer of that, in a way, we're not looking at just one organ system. We're not just looking at the heart or the pancreas or the brain or just like a bug, for example, an ID. Rather, what I've done in my clinic, and this is something I've learned through my residency training, is that these medications just don't target one organ system. Sometimes there's crosstalk with other organ systems, such as the liver, the heart, for example, even the kidneys. And so my approach is to look at the patient as a whole and manage the patient not only for their HIV or hepatitis, but also manage their other chronic conditions. And I think that makes it more fulfilling, more rewarding, rather than just taking, the patient apart by organ system. That seems to be a traditional path that I was trained under. And now many pharmacists are performing more of that comprehensive population health care. And it's more, I think, also fulfilling for a patient to know that pharmacist is not just looking at medications for diabetes, but the pharmacist is looking for medications for other chronic conditions that the patient is taking. Now, specifically, what is the role of an ambulatory care pharmacist? Well, we provide ambulatory care services via patient assessments. So patients who come in for their diabetes management may receive the point of care A1C test, which is a blood test at that clinic visit to see where their hemoglobin A1C is. And this is indicative of how controlled their diabetes is. Pharmacists have been trained to also perform patient assessments where they can do a finger stick test. They can do a monofilament test on basically using this monofilament and tickling the bottom of the feet to see if the patient has any sensation. Because we understand that when a patient has diabetes and it is not controlled, meaning that their blood sugars are very high, the patient may lose some sensation in the extremities due to nerve damage from having too much blood sugars, basically. So that's one example. We also have prescriptive authority to manage the various diseases through medication use and providing collaborative drug therapy management. So this is usually done under a collaborative practice agreement. And so I'll give you my example is that when I joined Ultimed as part of my practice site, I work with a medical director where basically I agree on these terms within my scope of practice to provide for their patients. And so I could order labs, I could prescribe medications for HIV treatment, hepatitis C, also chronic disease states, diabetes, hyperlipidemia, hypertension. So in a way, it is not restrictive of what I can do, but rather it is kind of like unlimited access. Now, of course, I have to be real with the medical director and the group. is that I should not be ordering x-rays. I should not be ordering ultrasounds of the liver because that is beyond my scope of practice and also something that I wouldn't be comfortable with because I'm also licensed. So that's one thing that holds us all accountable is our pharmacy license. And we need to make sure we practice within our scope, but also at the top of our licensure. We can order, interpret, monitor medication treatment related tests, and we coordinate care with other health experts and case managers and social workers. We provide education to patients and caregivers, and the main goal of doing this is to help patients better understand why they're taking their metformin, why they're taking their amlodipine or lisinopril. These are medications for diabetes and for hypertension, for example, because I believe that the more patients understand how these medications work to improve their health outcomes, they're more likely to take them as prescribed and become more adherent to them. And the other thing that we do is that we do document our interventions, our encounters with our patients in the medical chart. So in a way, this also tells the medical group, the medical team, for example, that I exist, that my interventions are part of that legal document in the patient's chart. So, for instance, when you go see your pediatrician for your annual wellness, for your vaccinations before you start school next, perhaps next fall, for example, they will put in their impressions and their interventions for you based on what they're doing. So ambulatory care pharmacists are also doing that. So there will be notes from the pharmacist as well as the physician and the nurses in the medical chart. The other part that I alluded to earlier is the transitions of care model. And this is a huge potential for integration of inpatient versus outpatient. This is where the pharmacists do play an important role to perform medication reconciliation in terms of that therapy management. And there are evidence that demonstrate elements for success where usually the transitions of care pharmacist model have a multidisciplinary support and collaboration between medicine and nursing. And there are data available to justify the various resources needed for that position. For example, the transitions of care pharmacist, which is technically an ambulatory care pharmacist, but on the inpatient side, they help to minimize readmissions and reduce the length of hospital stay for that patient. They also help to evaluate how often does a person return to the ED, emergency department. And they're pivotal in resolving medication-related problems by performing medication reconciliation to determine if there's any duplication of therapy upon hospital admission and hospital discharge, if there's any significant drug-drug interactions. And also they help as part of a team to for that medical center or hospital to meet the various disease specific metrics that the various health insurance have put out for reimbursement. And some of these metrics include the patient satisfaction or hospital consumer assessment of healthcare providers and systems. It's such a long word, but the abbreviation is called HCAHPS. And so HCAHPS, as well as HEDIS measures and leapfrog, all of these terms are medical terms that are used by health systems to measure the impact of their interventions and also how they have an impact on patients' outcomes in general, as well as satisfaction of service. There's also electronic patient information and data transfer between the inpatient or hospital setting to outpatient partners, mainly the primary care providers, including the community settings such as community pharmacies that the patients go to. And then lastly, there's a strong partnership network between hospital and outpatient setting for this type of transitions of care model. Now, what I want to share with you here is provider status for pharmacists within California. And becoming a federally designated provider means that pharmacists can participate in the Medicare program. Many of us know that we have a burgeoning level of baby boomers. Baby boomers are adults who are born between 1945 to 1965. And so they could be your grandparents now. And so they may be seeing pharmacists alongside with their physicians. For example, And so the whole point for this provider status at the federal level in general is to be able to see older patients and be able to bill for their pharmacy services within, of course, their scope of practice. Now, there are 38 states that recognize pharmacists as providers, including California. So, fortunately, you live in a progressive state that recognizes pharmacists as healthcare providers. In 2014, Governor Brown signed Senate Bill 493, which recognizes California pharmacists as healthcare providers and expanded their roles beyond just vaccination, beyond just dispensing medications in the retail setting. And more recently, from 2021 up to even now, 2025, there have been several legislation that have been endorsed and supported by APHA, the American Pharmacists Association, as well as ASHP, the American Society of Health System Pharmacists. So these are really two large national pharmacy organizations that came together to work together to push for legislation where of course, through the federal government to allow pharmacists to be recognized at that federal level. And so this was a bill that was signed by a Republican as well, oh, excuse me, endorsed by a Republican and a Democratic Congress people to have that recognition. It's still pending. It hasn't been approved or even hasn't passed the House of Representatives yet. But both APHA and ASHP have not given up. It's a continuing, persistent effort to help pharmacists be recognized at the federal level so that if you were to practice in Las Vegas, Nevada, or Phoenix, Arizona, and you're taking care of older patients, 65 years and older, then you should be able to bill for your services. And seriously, who doesn't like to get paid for their services, right? Because I think many of us long time ago have been very kind, very nice to just work for free. And then, of course, older pharmacists recognize that's not a good business model because then when you are working for free, people don't really value your expertise and so they'll take you for granted. So that's why it is important that we are recognized at that federal level. But the upside to this is that it's a constant fight, and it's something that both organizations as well as other non-pharmacy organizations are supporting. And the main reason is because there is a big shortage of medical providers. Simply, there is a shortage of physicians in the US right now. So it is a great time for pharmacists to step up and fill that void. Now, what about the impact on patient care? How do ambulatory care pharmacists have this impact, and what does the impact look like? Well, achieving provider status is about giving patients consistent access to care that improves safety, quality, outcomes, and also to reduce costs, mainly cost to the healthcare system, but also cost to the patients. Because many times, and I presume many of your parents, when they go see their providers or their physicians, they walk away usually with a prescription. And so it's seeing their primary care provider and then maybe perhaps a specialist. So every time they go see a physician, for example, they get a prescription. So you can imagine that every time they come to a pharmacy to fill each prescription, it is an additional copay of $10, $20, depending on the medications and also the insurance coverage. So if we can be in between the patient and the physician and to help to streamline the medications and make sure that the medications are appropriate, then hopefully we can reduce their outpatient or excuse me, out of pocket cost for getting that medication. What we also recognize is that 30 million people have gained access to medical care in 2014. 17,000 primary care physicians are currently needed and another 40,000 more by this year. So this is a big chunk of a number to really address and recognize that this is a significant gap of primary care physicians in our society. And so we also recognize the reality is that we have an aging population. People are living longer, which is great, but who's taking care of them? So you have a physician shortage, but on the other end, you have more people who are into that 65 years and older category. So then, of course, we recognize, okay, can we fill the void? And I'd rather have a pharmacist fill the void or the gap than a PA who has only 2 years of education after, of course, their undergrad and additional experiential education or training, but they don't have a doctorate degree and they will be working directly under a physician. Many patients are seeing nurse practitioners, and that's great. I work alongside a nurse practitioner, and she's amazing. But also, their understanding pharmacology and medicine is limited compared to a physician or even a pharmacist. So in recognizing that there is this big gap that someone should fill it, so why not pharmacists? So we recognize that pharmacists represent the third highest number of licensed healthcare professionals, approximately 300,000 and counting. And guess what? We're the only medication experts. And so if you recognize that older patients tend to take more medication, so there's polypharmacy. And many of these medications are prescribed by specialists and other providers who may not talk with one another. But if you imagine having a pharmacist in this picture, in part of this cycle of patient care, then that pharmacist can reconcile all those medications from physician A to specialist C to specialist D, for example. So, in a way, to help patients improve their health outcomes, but also to minimize any drug toxicities, bothersome side effects, or even major drug-drug interactions. Acknowledging pharmacists as non-physician providers in the Social Security Act will also allow licensed pharmacists to better assist patients by working collaboratively with physicians and other healthcare providers, allowing for autonomy to provide care and optimize medication therapy. And usually this is done through legislation or through a collaborative practice agreement with that medical system. And it also increased access for patient-centered care in medically underserved areas. What I mean by this here is that because of the physician shortage that exists now, in the remote areas, rural areas, such as, for example, Fresno, Bakersfield, there's not a lot of physicians who want to go out there and practice simply because of the quality of life, or also there's not a lot of pharmacies out there that is located at the corner of every block, for example. And so there seems to be a shortage of providers out there, but also there's not a lot of pharmacies out there for patients to travel to get their medications. So this is very important where pharmacists could be there to help fill that gap because we have over 300,000 pharmacists in the US and we can help. Maybe perhaps someone likes to live out in the rural areas. They have family there, so they can be that healthcare provider alongside with the physician. Pharmacists can provide primary care and manage chronic diseases by improving outcomes of care for the patient, enhancing medication and patient safety, reducing cost of care to the system, as well as out-of-pocket costs to the patient. And they can expand access to care by having the patient see the pharmacist for perhaps certain chronic disease states. And then when the patient has more urgent issues, then they can see their medical provider. So in summary, the key takeaways of this presentation, and I hope that you get to walk away with more information and knowledge, is that pharmacists are key players between prescribers and patients. We do offer and practice medication therapy management or offering MTM. We reconcile medications when patients are going into the hospital or leaving the hospital. We also monitor medications closely for toxicities, contraindications, and possibly overuse of medications that could harm the patient. And end of the day, our main mantra is basically to ensure patient safety for them. We develop personal medication care plan for each patient, and this is specifically for chronic disease state management and medication therapy management. And we do take every opportunity to adapt to the changing environment. And I say this because we have pharmacists also in sports medicine. So for some of you who might like athletics and want to go down that path, there are special programs for that. And if you're a big animal lover, there are pharmacists practicing in veterinary medicine as well. So we have pharmacists doing that, just veterinary medicine and compounding medications for horses, cows, dogs, cats, etc. And recently, I just talked with a first year Chapman pharmacy student who wants to do Errol, I think it was neurospace pharmacy, and I thought that was really different. I've never heard of it, but she wants to work alongside the NASA astronauts and help them with their medications when they're leaving Earth and coming back from space, those things. So I thought that is ingenious and creative. So that's the great thing about pharmacy is that if there's a position or a passion that you have that the position is not there, you can create it. So that's a flexibility with this profession. And of course, just apply your pharmacology and clinical knowledge, and that will help you along the way to make to become successful in this field. So that's it for my presentation. Please let me know if you have any questions. I'm more than happy to answer them.
All right. Thank you, Dr. Lamb. So students and parents, what questions you guys have for Dr. Lamb?
Well, I'm curious as you're thinking of the questions with the group that we have. I'm curious, are you sophomore? I mean, what year are you in high school right now? Are you in your 11th, your 12th year, 10th year?
I'm a senior in high school.
Oh, okay. Wow. So you're making your decision right now.
Yeah, I like applied to Chapman like 2 year or 2 weeks ago.
Okay, great, great. So looking forward to lecturing on the same presentation for you next fall. But I'm glad. So many of you are seniors. That's great.
Yeah, and they've been putting in the chat, Crystal, Greta, Maya, and Bella.
Hmm.
They're all seniors.
Hmm.
Hmm. And so did all of you guys submit applications already? Okay, very good. So instead of a question, maybe you guys can say what you found most interesting about the presentation. Like what surprised you? Like what did you hear that was new that you didn't know about? Nothing? You guys knew all this stuff about ambulatory care, or are you just too shy to mention it?
Um, I guess I can go. Just like the amount of like need for like ambulatory care pharmacists, like I didn't know it was prevalent in such like a wide array of settings.
Hmm. Yes, definitely. And that's a great observation. When I started out as a pharmacy student, I, I was just thinking, I was only aware of hospital setting and retail setting. And I didn't know much of ambulatory care until my residency training, where I got to really see what ambulatory care pharmacists were doing. Of course, I had some exposure when I was a fourth year student and going on my experiential rotations, but that was just 6 weeks. But when you're a resident, this is post-grad training, you get to really get into the depth of training and clinical experiences. And I got to see the impact. I think the one rewarding thing that I can say about ambulatory care is that you do get to know your patients over the years, just as you got to know your pediatrician over the years, right? And you develop really good friendship with them, and they would bring you gifts around the holidays. They're grateful, and I think that is kind of like the bonus. But the great thing is that you get to see the good results of your interventions, your medication therapy management, the medications that we give to our patients, making sure they're doing well. You get to see the positive outcomes in terms of improving their diabetes, their high cholesterol, their hypertension, those things. So you get to see that versus in the hospital setting most of the time you're just grateful that they get discharged home and they're not coming back because you don't want them to stay in the hospital too long, and so you don't develop that rapport with the patients. You will develop rapport with nurses and physicians, of course, but you can do that also on the clinic side. So I think that's a rewarding thing, and if you're a person who loves to talk and make new friendships and relationships with people, then clinic setting is the right setting for you.
Yeah, very good. And I would say too, I think um, Dr. Lamb's patients appreciate the fact that she keeps them out of the hospital as much as possible, right? So we had Crystal in the chat make a comment, say, I'm surprised that there's so many positions you can have as a pharmacist, which is very true. Lots and lots of different things you can do, and more are coming out each year. Maya says the transfer of care from inpatient and outpatient has become very smooth. For sure, that transitions of care has become really important in pharmacy. And I'll get to yours, Crystal, in a second. Greta said, I was surprised by all of the responsibilities and scope that ambulatory pharmacists have. Yeah, I mean, you guys do take care of a lot of things because you're talking about chronic disease patients for the most part, and they have more than one condition, not just the main one.
Mhm.
And then Bella says, I didn't know that making the transfer process smooth was such a big aspect of ambulatory care. You want to talk a little bit more about that?
Yes, yes. In terms of the transitions of care, if Bella's question was about that,
Mm-hmm.
they're usually placed in the hospital setting, and they work alongside the nurses to ensure that smooth discharge, hospital discharge for the patient. And then when the patient comes to see us in the clinic, they'll of course see their primary care provider, usually a physician, and the ambulatory care pharmacist is there as well to see them to reconcile medications and also to make sure that their preferred retail pharmacy has the current medications. Because when a patient is hospitalized, sometimes the medications are changed based on their condition. And so sometimes the medication can be discontinued or added on. But sometimes the hospital won't have the full list of medications that the patient came in with. And so this is where ambulatory care pharmacists can be that, I guess, transitions of care pharmacists on the outpatient side to reconcile any discrepancies, any duplications, any omissions that can happen. That's for sure.
Yeah.
Now, to Crystal's question, I do work in a clinic. It's a clinic setting, and we call it a team room. So I have my desk in this clinic, and two desks down is the physician, the nurses, and the MA medical assistant. So we all work together in one room. And I at first we didn't really like it because it got noisy, but eventually you kind of know how to filter out the white noise. But I do like it because one thing I noticed in my previous practice model is that I would be in a corner somewhere. And then, of course, the physician's office is next to mine, but it's kind of like we're divided by a wall. And then the nurses have their cubicles or stations. And one of the things that I recognize is that when I'm not in the same team room, it's kind of like out of sight, out of mind. And so I don't get a lot of referrals or questions, like drug information questions, versus when I'm there in front of them, they're more likely to come and say, "Hey, what do you think of this?" Or what are your thoughts about trying this new medication? Patient's not responding to two antihypertensives. What are your thoughts of adding a third one? Those things where, because it's easier for them just to walk up to my desk.
Yeah, very good. All right. Any other thoughts or
Mhm.
Maya says, what made you choose infectious disease as a specialty?
Yeah, yeah, that's a great question. I chose it for two reasons. I didn't have a good ID professor, that's for sure. And I say that honestly because it wasn't just me. And so it made me more curious to learn about it. And second, I felt I had very good mentors. I think that really influenced my decision to go down the path of infectious diseases was that during my residency, and I had, I rounded with medical teams. So we had an ID physician, ID pharmacist, myself as a resident, and also an ID fellow. And they were just really supportive. And I think the mentorship is very, very important. And so they were more open to teaching and accepting different ideas towards patient care. And so I think that really influenced me to go down that path.
Mhm.
Yes, in terms of other healthcare workers, in my practice setting now, not as much because we're more like we work together as a team and it's more like an ID team. But in terms of my previous practice settings, I did work with psychiatrists because that was something that many of our patients with HIV had. They had depression, they had mental health issues. And during my fellowship training back at USC, I also worked with women and children with HIV. So I got to work with pediatricians and also OB-GYN or gynecologists. And so that was also fascinating to see their perspective and how they approach women with HIV and also children with HIV. So it's overall it's very rewarding for me just to be on the ambulatory care side. I do miss the hospital side because it's more fast-paced, more dynamic, but I wouldn't trade it because I wouldn't get to know the patients that I know now.
Good.
How long was my residency? It's 1 year, and generally that's required nowadays or strongly preferred if you want to work in California, especially. But there's also second year and third year residencies. But second year is more common for those who want to specialize, like in ID, in cardiology, in psychiatry, etc.
Mm.
Um, what do I think the projected growth for ambulatory care locally here in California? Well, one thing for sure, my sister-in-law is an ambulatory care pharmacist also with Kaiser. And one thing for sure is that ambulatory care pharmacy positions are very coveted. They're not easy to grab. They're not easily open. And if they are open, they're taken up quickly based on seniority within Kaiser and other places. So the reason is because it's very set hours. It's kind of like being a primary care provider where you work 9 to 5, usually, or 8 to 4:30, for example. It's 5 days a week. You don't work weekends. You get holidays off and you get paid very well. And I think the other rewarding thing is that you're able to make interventions, you're able to treat patients, and you get to see the positive outcomes coming back. So that's why it is so coveted, and a lot of people, yeah, are vying for these positions. So it's rare to have a position open, but when you are trained for after you graduate, you are poised for being in that position. And there are also second year ambulatory care pharmacy position or residency trainings that you can dedicate your expertise in so that when the job opens, you're more likely to get that job than someone who has no clinical experience in that area.
And can you say a little bit more about veterinary pharmacists?
Yes, so I said this because a friend of mine, her brother was basically, I don't know how his training was, but he opened his own pharmacy and it was dedicated just to, veterinarian medicine. And he was able to get his pharmacy, and it's more like a retail setting where there's a dedicated hood and room for him to compound medications. And I don't know too much other than I think you just need to get some certification in that area. I don't think there's residency training there yet, but it's something that I know other states have offered certification for additional training. But it is lucrative if you are, someone who loves, animals and want to make a lot of money, because a lot of health insurance will not cover medicines for pets, and so it's usually cash paying patients. And
Uh,
his pharmacy was located in Westlake, which is an affluent area. And he was doing so well that he got bored from what I understand. He went back to school, pursued a JD, a law degree, and he's happier practicing as a pharmacist lawyer also,
yeah.
or attorney.
Yeah. And the main thing with veterinary pharmacists, it's pretty much mostly compounding different
Hmm.
medications for animals since there's not a lot of manufactured medicines for animals. And it could be big animals, like horses, cows, bulls, right? Elephants, or I think the person in Westlake probably did more small animals like pets
Hmm.
and so forth. So,
Yeah, and for those who have pets, they're like family members, right?
mm,
And so we would pay an arm and a leg to make sure they get their medication and do well.
yeah, for sure. All right. We have a few minutes left. Any final thoughts or comments? All right. Well, seeing none, thank you guys so much. I don't know if you're coming to the info session that we're having tomorrow. I'll be doing that info session. I think a couple of you guys have already been to an info session. Um, but so glad to have you here. Hopefully, you're as excited about coming to Chapman as we're excited to have you here at Chapman. So thanks again, and please reach out if you have any other questions.